Good afternoon, everyone. Welcome to the APASL COVID-19 webinar, which is the portal where the APASL can communicate with our members, and you can have portal to ask questions during this webinar. For the episode 2, the APASL COVID-19 task force, under the guidance of Professor Sarin, who is chair of the APASL steering committee. So we now cover more hepatology updates. And this is the session 3 of episode 2. I'm so honored to have Professor Hsiu-Hsi from Malaysia to co-moderate the session. Without further ado, I will pass my role to Professor Hsiu-Hsi to say something and to introduce our first speaker. Professor Hsiu-Hsi, please.
Thank you very much, Professor Tan Wan Di. Good evening and good afternoon, ladies and gentlemen. Welcome to our APASL COVID-19 webinar episode 2, session 3. I am Hsiu-Hsi from Malaysia, and I'm greatly honored to moderate this session with my friend and colleague from Thailand, Professor Tan Wan Di. Today we have two exciting topics. First one is the COVID-19 situation in Taiwan. Why exciting? Not much has been reported in the mass media about how Taiwan is handling the pandemic. I checked the WHO website this morning and there was no help. So perhaps we hope Professor Chen will enlighten us on how he handled the situation in Taiwan. The second topic is, of course, acute-on-chronic liver failure. Why is it exciting? Well, it is exciting because the speaker, Professor Sarin, such a consummate and respected hepatologist with a challenging topic, acute-on-chronic liver failure, an update. So I leave it to Professor Tan Wan Di to introduce Professor Sarin later. Let me begin by introducing our first speaker, Professor Chen.
Yes.
Now, Professor Chen is currently Professor of the Institute of Epidemiology and Preventive Medicine at the College of Public Health, National Taiwan University, Taipei, Taiwan. He's also the Associate Dean of the College of Public Health in the same university, as well as Director of the MPH program. Now, Professor Chen is an expert in the evaluation of intervention program with emphasis on population-based cancer screening and also universal vaccination program by using a series of complex statistical modeling to deal with several thorny issues that cannot be solved by classical approaches. Now, these include the development of different health economic decisions for cancer screening and also vaccination program and prophylactic treatment. Now, regarding international academic cooperation, Professor Chen has taken the presidency of the International Asian Cancer Screening Conference Network, held annually since 2004. And as far as collaborative research in Western countries is concerned, he has a long-lasting collaboration with Sweden, USA, United Kingdom, as well as Finland. Now, Professor Chen was awarded the Finland Distinguished Professor issued by the Academy of Finland between 2007 and 2009. It is now with great honor and pleasure that I invite Professor Chen to talk on the control of COVID-19 in Taiwan. The talk will be about 20 minutes with 10 minutes of questions following the talk. Professor Chen, please. Thank you.
Okay. First of all, thank you so much for Professor Hsiu-Hsi for introducing me, and it's my pleasure to have this speech here, and thank you for the APASL to invite me to give this talk to show how we control the COVID-19 in Taiwan. So first of all, you can see from epidemiology viewpoint, you see we have a low incidence rate compared with the global level until 18 June, and we also have the low case fatality and the high recovery rate. So this is actually until so far Taiwan's the epidemiology profile about COVID-19. So how can Taiwanese government can have such a success? It's because of the several preventive strategy before the discovery of the vaccine and the antiviral therapies. So the first thing is about border control. Of course, we have the symptom-based quarantine and also the pre-symptom, also asymptomatical for the safe home quarantine and also isolations. We also have a mitigation plan and also some of very good epidemiology investigation. I will show you later on. And because of the border control, you can see 88% case, from imported case, and only 12%, are domestic case. And the imported case actually geography distributed in northern Taiwan and also in southern Taiwan because of the two airports, one Kaohsiung, one Taoyuan airport. And so if you see the epidemic curve, the Taiwan actually has two important time points to have the border control. One is on 7 February after the outbreak of the China. So we have a ban from passenger from China, Hong Kong, and also Macau. And the second time point, for border control is around the 19 March after the outbreak, and also not only in the ASEAN but also in the European and also in USA. So these 2 points is very, very timely to control the imported case from country outside Taiwan. So that's why you can see after about May, we don't have the domestic case. So until so far, over 2 months, we have little case, about the COVID-19. So this is actually one of things very important, the policy for border control. So I use the Poisson models to model the imported case as a denominators and the domestic case as numerators to predict, you see, the curve about the occurrence of the COVID-19 in Taiwan. So the original curve is a predict, and the blue one is observed. So if you use the 19% confidence interval to see, the upper limit actually is a threshold for having the community-acquired infection. This is so important because if you don't stop community-acquired infection, you have a large scale, the outbreak. But we already have a small cluster, you see, including family and hospital and also the academic institute. But fortunately, they don't cause, community-acquired infections. Why? Because we have a mitigation plan, including the personal protection, and also social distancing and also environmental sanitations. And let me introduce one by one. So at the beginning of outbreak, because of SARS experience after 2003, you see the people are long queue for the facial mask, and also the government, have a compulsory policy for ask people to wear a facial mask indoor, and also to request them to wear facial mask during when they take the public transportations. This is very strict control. And we also have a very strong, advertisement about the wash hands with frequency, and also how to select the facial mask, and also how to put on and also remove the facial mask. So this is the advertisement, and also you can see the Taiwan government also have a very good management about the PPE for healthcare worker and also the healthcare institute. And we also, the government also subside the production of the facial mask by, making use of the military, force, and to produce, they can produce, the facial mask in time to supply the domestic and also the foreign country supply about the facial mask. So this is one of things. You see, the one of reasons suggests why we always have the small cluster infection, but we don't lead to the large scale, the community acquired infections. The second reason is about social distancing. The social distancing is, it's not very easy to do, but in Taiwan, you see, we learn experience from the foreign country about, religion, the public gathering, pub, and the sport and nursing home, and also the concert, and so on. So in order to reduce the public gathering, to reduce the contact, you see, we propose the social distance. So for indoor, we at least keep the 1.5 meters distance. For the outdoor, we keep the 1 meters. And if not, you should wear, the facial mask. And very important, even the large scale of the public gathering because of Buddhist, gathering. And there is the very important Buddhist gathering. Each year, about 2 million, attendants. So they consult with our academic site to evaluate, and we and then also government advise them to, postpone. So they follow our advice to postpone this public gathering. And not only for that, we also encourage the cyber condolence, because during the March and April, Taiwan has a festival for condolence for ancestry, So they also follow our advice to use the cyber, condolence. You see, so they reduce the contact rate, because of the public gathering. And for the school, we also use the online educations to have a social distance to reduce, the contact rate. So this is why I think Taiwan has no, large scale of the community acquired infections, and so we don't have the epidemical, large epidemical situation here. And about the household infection, we still have household infections. I show you one case. This is the beginning of the outbreak from China. You see, there is a taxi driver, contact with the passengers. So the index case is here, and he just, infected 4 persons within the family, one the mother and the doctor, and also son, and also a son-in-law of her sisters. So there's 4 cases, and but after that they don't cause again large scale of the epidemic. So based on household infection, we still have very the high infection rate during households, just as you have seen in the Western countries. It's about 34, compared with the influenza is only 8%. But because we have a mask and also washing hands, so we can down to 20% here. So I just show you to explain why there is no community acquired infection, and this is so important to convince of the government and also people, to reduce the contact rate, and also to due to the social distance, and also reduce the transmission probability by wearing the facial mask. So this is just show you this case, the taxi driver case. You see, even they have a frequent contact per day, 20s, but we have a low transmission probability because of the personal protections. And for infection period, generally speaking, is 5 days. So you can calculate it's only imposed at 0.77, so it's a reproductive number is less than 1. That's why it's plain. But we even have very the good measures of reducing the contact traces by using the digital contact tracing. So the formal case is is to show you even the taxi driver have contact, have such a contact rate, but we use the digital contact to reduce the contact rate as small as possible. So this is just show you the digital contact tracing by using, you see, the CCTV and also our national health insurance claim card to know the traveling history and also contact history, and combined with the political system, and also health official to have a very quick contact tracing, and police system use the geo-prediction, and also their database, to shorten, the contact tracing time in order to reduce the contact rate. So compared with the conventional contact tracing, you see, because of that, we reduce the contact rate to contact with a suspected infected case. So this is just show you, the picture about when the health official accompanied with the police system to visit, the people, with the safe quarantine and also the safe isolations, and to make sure they don't go out to infect other peoples. So in addition to this digital contact tracing, the government, make use of the data, different kind of database as a central database from the immigration history, political system, geopolitics with the mobile phone and also the mobile PPAs, and also sometimes we have make use of the credit card and also some of the other database through the CCTV, for traveling footage, discovery, and also important sense is national health insurance. So because of the central database, you can do the quarantine isolation and the compliance isolation, and also digital contact tracing, and also the surveillance for the disease here. So this is just show you the one typical case about the Diamond Princess when they disembarked from Keelung airport in northern Taiwan. And because it is a high contagious of the reproductive number 5, so the government, initiate the contact tracing by, tracing the footage of the passenger and identify the possible contact person and send a cell message for intervention, and also alert message to ask them to stay at home. And if they have a symptom, and send them for the test, and also use the national health insurance system to follow their visit to hospital. And once they have a symptom, they send for test. So this is just show you the left side is use the geo-prediction to identify the footage of the passenger, and also their possible contact, and send alert, the message to the resident on the neighborhood of the passenger, and also send alert message for intervention to ask them to stay at home. So this is actually quite interesting, the digital, things to do such kind of the contact tracing. And the very important thing is, in addition to contact tracing, we have a surveillance of the COVID-19 from arrival of the passenger to ask them to quarantine for 2 weeks, and also the contact to ask them quarantine for the 2 weeks as well, in order to reduce the pre-symptomatic case to go out to infect other peoples, and also a symptomatical case as well. And we also have the community acquired, pneumonia surveillance, and also some of the patients with the suspected symptoms. We ask them, we send them for testing RT-PCR, in order to reduce, the more contact with other peoples, particularly in the healthcare work institute, and also healthcare workers. So finally, I think even we have success in achieving such a containment of the COVID-19, we still want to prevent, second wave of COVID-19, by continual active surveillance and maintain, the containment measurement. And very important, we want to do the zero prevalence survey to see whether we still have an antibody positive for some asymptomatic case. And of course, in the winter time, coming, you see, we have to also increase coverage of the flu vaccination and also PPV, because not only in the COVID-19, the flu and also the pneumonia is still, straight to Taiwan as well. And of course, just we mentioned about India and about the, not only for the COVID-19, you see, we have the chronic disease because they don't visit hospitals because of COVID-19, period. So we want to renew this clinical visit for their management of chronic disease. Finally, I think, for international the standard, I would suggest, to leave the border control for each country. In Taiwan, we want to also lift this ban very soon, but we have to do the reassessment for each region and the country, in the world, in order to know which area right now is has no epidemical and which area has epidemicals. And not only for that, we also wanted to give the test for antibody and antigen in order to provide the immune passport, and to enhance the global safety for being protected from COVID-19 infections. I think this is my speech, and thank you so much for your invitation. Thank you.
Okay, so the measures that have been taken by Taiwan are more or less similar to the ones that have been taken by Malaysia. Can I ask just a couple of questions?
Sure.
How's the population? How do they take it? I mean, the stringent measures that have been introduced by the government. What is the response by the population, the Taiwanese? That's number one. Number two, you mentioned that the case fatality rate of COVID-19 is 1.6%. Is that correct?
Yeah, yeah.
Now, how does that compare to the case fatality rate of the normal influenza cases that you get? So those are the two questions.
Okay, I think in Taiwan is Taiwan is 23 million people there. So generally speaking, they have, I think they are very have very good compliance with the government policies. I think their response to government policy and also the policy from border control until mitigation plan, they are, I think generally speaking, they are quite satisfied to this. So that's why they have very good compliance with this social distancing and also personal protections. So this is the first question I answered to you. According to the survey, I think the certification, the response rate to the certification with the government, I think it's about 90 to 95%. It's quite high, according to some poll surveys. And the case fatality actually is 1.6. I think it's because of compared with the 5% right now in the world, but don't forget the denominator is from case. So because we have a few cases, so we have healthcare, a very good healthcare capacity, particularly for critical care capacity, to provide good care. So that's why they have a low case fatality. And but I can share you my experience because the case is not very heavy, so they can have a long day for hospitalization in the hospitals. So that's why they have a very good care about this. I think this is why the case fatality is low.
Okay, Professor Tan Wan Lee, you want?
Oh, Professor Chen, there is a question regarding the N95 respirator. What is N95 respirators considered as a surgical mask?
You mean the difference between the N95, the mask, and also the medical mask?
No, they just ask whether the N95 is considered as a medical mask. I think it's going to be maybe good for protection or of the infection of the COVID-19 or any airborne infection?
Yeah, we for people we don't suggest them to wear the N95 only for the healthcare the healthcare persons, you know, when they work at hospitals to care, you know, the patients. So they only have a N95. I think you know 2 days to have a N95 according to my best knowledge. Yeah. But we don't ask them to people to wear N95. Yeah.
Yes, but I think maybe they are asking whether the all N95 masks are the same. I think there are two grades: the surgical medical N95 mask, which is outer side water resistant, and the industrial grade N95. That is just for prevention of the particle.
I think, you know, we use only the conventional medical mask, the surgical mask, rather than the N95. You know, so
right. N95 is going to be used for those who are take caring of COVID positive patients.
That's right. Yeah, that's right. Yeah.
Any question from Professor American?
Well, those are the questions that I asked just now. So any other question for anybody else? If not, perhaps Professor Tawandi, you might want to introduce Professor Sarin.
All right. So Professor Chen, just hang around. So after the Professor Sarin's presentation, maybe there are going to be more questions coming.
No problem. I'm here.
Oh.
Yeah. So
thank you very much, Professor Chen, for your presentation. Thank you very much.
No, I will join until end of meeting. Yeah.
Okay. Thank you so much, Professor Chen.
No problem. Yeah.
So now it's my great honor and pleasure to introduce Professor Shiv Sarin, who is Senior Professor at Hepatology and Director of Institute of Liver and Biliary Science, New Delhi. And he is chair of our steering committee of the APASL. He is well known to all of us. Actually, he doesn't need any introduction. His interest in several areas, including liver diseases, especially for the variety of bleeding, liver regeneration, hepatitis B, and acute-on-chronic liver failure, where he has published several hundred publications. Many are landmarks paper nowadays. He chairs many task forces. Among those is the APASL ACLF Research Consortium. He has received several national and international awards. One of those is a Henry R. Bockus Medal by WTO in 2017. Today, he will talk to us on the acute and chronic liver failure. Professor Sarin, please.
Thank you, President APASL. Thank you, Professor American and Professor Chen. After the great achievements of Taiwan in the COVID field, I will give you something related to the current scenario in ACLF. I bring greetings from the Institute of Liver and Biliary Sciences. I have no conflict of interest. I will try and give you definition updated and models of assessing severity and the management options. So if somebody has a normal liver, gets an acute insult, it is acute liver failure. Somebody has a decompensated cirrhosis, gets an acute insult, then there is further worsening of the decompensated cirrhosis, and sepsis, bleed, AKI, and HE can develop. These are two different scenarios, end stage and normal liver. We have another scenario where there is a chronic liver disease, means F2, F3 fibrosis, an acute insult can develop, or a patient who has already got established cirrhosis, not decompensated. The two insults are distinct in their patterns and behaviors. Now, a compensated cirrhosis gets an acute insult. You call it as acute decompensation, AD. This can be a GI bleed, it can be an HE, it can be an ascites, HRS, sepsis, or any combination of this. So this is one form of acute decompensation. Another form of acute decompensation is liver failure, which is jaundice. And if this is present in a chronic liver disease patient, it is acute-on-chronic liver failure. Jaundice occurs with an acute portal hypertension presenting as ascites. So for homogeneity means out of all types of acute decompensation, one decompensation which is with liver failure and ascites is what the APASL has defined as ACLF. On the other hand, the CLIF, the European Association, includes chronic liver disease, compensated cirrhosis, and decompensated cirrhosis. And this includes about 29 different variants of liver disease, but all of them may or may not have liver failure. And the third category of definition is by the North American Consortium for End-Stage Liver Disease, which only includes the decompensated cirrhosis, but they can have different presentations with or without jaundice, and that is heterogeneous. So this is homogeneous, this is heterogeneous, and this is heterogeneous therapy. Now let's look at the two common definitions, the APASL or the CLIF definition. You may have sepsis or any other acute insult, and extrahepatic organ failure like AKI or pneumonia or something can occur, and this extrahepatic organ failure can proceed. Or liver failure can be there, but liver failure is not the primary event, it can be a secondary event to this. On the other hand, in the APASL, you will have a person who starts with a liver failure and extrahepatic organ failures come later. Initially there is no SIRS, but liver cell death leads to SIRS, and then immunoparesis and others. And there is a golden window of about 7 to 10 days where there is liver failure followed by extrahepatic organ failures. The mortality in this is close to about 40% or so. So what APASL does is to define early disease starting with a liver failure, while APASL picks up a distinct group of 3 different types of patient groups. So if you look into this, a person who has a normal liver is different, 100% of the liver. But in ACLF, you already have cirrhosis or chronic liver disease, and acute insult can bring it down. But the patient can have spontaneous recovery, which is the very important part. While in decompensated cirrhosis, it goes down slowly. Once you have it, can recover slightly, but very close to need for liver transplant and organ failure. So the two definitions are the APASL or ARC is an hepatic insult which is acute, has jaundice and coagulopathy, followed by ascites and or HE in a patient with CLD or cirrhosis with high 28-day mortality. While the CLIF-APASL definition is a condition within 4 weeks of jaundice or any other inciting event, and there is a failure of 2 extrahepatic organs, and mortality is up to 3 months, not 4 weeks, and it could be SIRS or bacterial infections. So here is somebody like you have a chronic pancreatitis, he has pneumonia, so he will be a chronic pancreatitis with pneumonia. Here it could be cirrhosis with pneumonia, cirrhosis with sepsis, but no liver failure may be there in these groups of patients. There is a recent update in NEJM where unfortunately APASL has been misquoted. The definition is given as APASL is based on opinion of experts. Unfortunately, it is based on a data of initial 1400 patients and now 7000. It also says and misquotes APASL that it is a non-cirrhotic liver disease, which is not correct. And these are very eminent people, so I would not like to contest, but just want to clarify, this includes both chronic liver disease as well as cirrhosis, and it is not based on experts. This is a prospective study. So let's see, the patient presents as hepatic insult or as a liver failure, but has underlying chronic liver disease. So there is A is an acute insult, C is a CLD or cirrhosis, which you can identify by endoscopy or biopsy, and the result of this insult is liver failure, and there is a reversibility. How do you approach? So you have to assess what is the acute insult. Any of these can be an acute insult. What is a chronic insult? These can also be like Hep B, autoimmune, Wilson's can be a chronic insult. So the approach is to define the extent. So this is the soil and the seed phenomena. How bad is the soil? And that is what decides the outcome. Having defined the syndrome, I'll give you the assessment of severity. Of the initial 3,100 patients, you can see mortality in 1 week is in about 1 in 5, and at 28 days is about 40% or so. And we therefore need to move fast so that we can make these patients live. I'll give you with a case. Here is a person who has come on 3rd week. Let's look at 3rd week. The 3rd week, the mortality could be 37%. He comes with a high INR, with a bilirubin of 22, a high lactate, but still hasn't got infection. He is negative for serology and liver is coarse and has ascites. In about 5 days' time, he has now set up with his infections. His kidney has become bad, his lactate is still high, and he has cirrhosis and has a high HVPG. This patient died on day 30. Now what is important for us to understand is the dynamicity, how the infection comes, how the lactate plays a role, what is the role of INR, that is liver failure, and bilirubin. So ACLF, liver is the driver. Jaundice, coagulopathy, encephalopathy, lactate, and then subsequently the creatinine. So our patient had no HE at baseline, but a bilirubin was high, INR was high, lactate was high, creatinine was less than 1. This gave him a score. These are points 1, 2, 3. Let's say bilirubin was less, he would have got 1 point. Bilirubin is high, he got 3 points. So this is what is known as the ARC score. He had a score of 11 at presentation. Now his grade of 11 means he is grade 3 liver failure. No other definition defines liver failure in a chronic liver disease. Acute liver failure, you have a definition of liver failure, HE, coagulopathy. But for chronic liver disease, there is no definition. So this is the first definition. And according to this patient has grade 3 liver failure. His score is 11. What does it mean? We will see. Now on day 4, 3 days later, day 26, he has now a lactate which is still high and creatinine has become high. So his ARC score is now 3, 3, 3 and 1, 13. Now what does it mean? A 13 score is still grade 3, but what is the outcome? So just to show you, somebody who has a score of 11 and then increases, every 1 unit increase makes his death probability by 20%. It's a dynamic score. So now he could have been transplanted here. Now it is a bit late. And this is to show you ARC score, scores above all other scores as far as the mortality at 28 days is concerned. There is a calculator available online. So to summarize this part, 28-day mortality is high, 21 days is about 30% or so. Liver failure drives other organs, and the ARC score uses bilirubin, INR, HE, lactate, and creatinine. And anything above 10 needs transplant. Let's look at how we manage, and there are many new things in this I hope to share with you. This is just to show you, this is in our guidelines. alcohol to be stopped or treated with steroids, autoimmune with steroids, and you can use up to 27 meld. Of course, drugs have to be removed. Antivirals, HEB, we do not know the best option, and if there is superadded sepsis, antibiotics. Now, this is something new, acute portal hypertension. Now, patients who have got cirrhosis have raised portal pressure. Now, acute insult due to cell death leads to a burst of cytokines, stellate cell activation, endothelial dysfunction, and impaired vascular relaxation. So, sudden rise in pressure from 12 to maybe 18 or 20. This leads to ascites, leads to hepatorenal syndrome because of poor blood to the kidneys, GI bleed, and HE. Now, this is a study we published in our journal. If you give carvedilol to these patients, there is a reduced progression of varices. It also helps you in improving the outcome. This is a very difficult and important study just to show you if you give beta blockers like carvedilol or propranolol, you can reduce 28-day as well as a delayed mortality. It hasn't come to significance, but you can see that first 28 days you can stabilize your patients because acute portal hypertension. Second important and new data is normally we do LVP, large volume paracentesis, but in a patient who was compensated cirrhosis, has sudden ascites, he doesn't have relaxed abdominal walls, intra-abdominal pressure is very high. So they can develop the circulatory dysfunction with 5 liters. To examine that, we came up with a concept of MVP, and this is 3 to 4 liters. It was published and very well received in Hepatology with a cover. So this shows you that if you do a paracentesis which is between 3 to 4 liters, still there is PICD. There is 70% of the patients will still develop. So if you have a high bilirubin and you tap even 3 to 4 liters, it is not good. You need to give albumin and still 1/3 will develop PICD. So please be careful for your patients for tapping if there is an acute on chronic liver failure. What happens to the kidney? These patients compared to CLD have much more AKI and its progression to chronic kidney disease. This is the first paper to show that a fair number of them developed ATN and CKD and type 1 HRS. And of course, we have shown earlier that these patients, terlipressin is not effective. So what do? So patients of AKI in ACLF, our patient developed in 4 days. You have a new AKI, so volume and albumin response is in about 30%. Avoid overload. If there is no response, which will be in 2/3 of the patients, start vasoconstrictors early. You may have a response in 1/3, may not have a response. Such patients may be considered for early dialysis, whether SLED or CRRT. But what is to just explain to you that organ failure is following liver failure. Encephalopathy, we define in our recent last year's consensus organ dysfunction versus organ failure. All the organ dysfunction should not go to organ failure. So grade 2 HE and less dysfunction. HE 3 and 4. Now ammonia for ALF is 120. For acute and chronic it is 143 with a high mortality. How do you manage? Ammonia targeted therapy and plasmapheresis. So liver support systems are for detoxification and they are a bridge to transplant in one way as well as allow regeneration and spontaneous survival. This is the famous Helios study where patients with high MELD, when they were given the fractionated plasma separation, they did better compared to a standard medical therapy. A similar data was seen by relief using Mars. What we have found, when you use FPSA, that is the Prometheus system, compared to that, which is very expensive, compared to that, a simple plasma exchange, which is normal volume, not large volume or high volume, can be equally good. And therefore, we can do in our patients a plasma exchange compared to the fractionated plasma serum albumin exchange. The next important thing after organs is sepsis and infection. We have shown earlier there is immune paresis in acute on chronic liver failure. The neutrophils, monocytes, T cells, and DCs are not in good shape, and giving a GCSF might be of some benefit to reduce sepsis and improve survival. So compensated cirrhosis or chronic liver disease has an acute insult. It may lead to ACLF. Neutrophil dysfunction is there, and to restore neutrophil function, you can give GCSF therapy. Now, if you restore neutrophil function, you actually can prevent sepsis. Remember, sepsis is a consequence of liver failure. And if you prevent sepsis, you can prevent further deterioration in liver, kidney, or brain functions. And of course, you can manage it with antibiotics. So prevent sepsis, prevent organ failure. And the dendritic cell function is extremely important. We did intrahepatic, the liver infiltrating lymphocytes, took out the DCs and found that the DCs don't work, and if you give GCSF, the DCs recruited 12 times more MDCs are recruited in the liver, regeneration as well as infections are decreased. So when you give GCSF compared to placebo, in GCSF, HRS, encephalopathy and sepsis can be reduced, and this therefore can lead to an improved survival, both by preventing sepsis and permitting regeneration of the liver. The regeneration is by two mechanisms by GCSF. One, by stimulating the hepatic progenitor cells by working on the tweak expressing macrophages, and also by neutrophils, and here by mobilizing CD34 133 positive cells, which may by paracrine mechanisms or other can help in liver regeneration. There are several trials where this therapy for both combined groups, cryptogenic group, for hepatitis B, for alcohol, GCSF has been tried in these patients. There is a small role of FMT. We showed in an earlier study of severe alcoholic hepatitis, which was not eligible for steroid therapy. In the anecdotal study of 8 patients compared to control, FMT was found to have an improved survival. And the same was shown in ACLF due to hepatitis B. With all humility, this was given the best oral award in last EASL. The tenofovir alone gave survival of 53%. Tenofovir helps only virus, but the liver failure part was helped by FMT and showed an improved survival in these patients by changing bacteria. Liver transplant remains the final savior. This is the data to show you of nearly 800 plus patients that if transplant is done in time, you may have 4 out of 5 they can survive. There is now data of more than 7,000 patients of ACLF in the ARC database, and I encourage you to please contribute and educate us and everybody else who has joined in ARC. We did a brief survey of liver transplant of the participating countries, 78 countries. We asked which definition do the transplant surgeons use. About majority said APASL definition. We also asked what is the cause for not transplanting, and not transplanting was late referral. Nearly 50% of them said sepsis has already set in, organ failure. So if you use the EASL Cliff or NASCL definition, which includes organ failure, I'm not against them. I'm just saying the surgeons say, oh, it's a bit late for transplant. So this is my last slide to show you that we have a consensus, and based on that, I'm giving you the management update. If the MELD is above 30 or ARC score is above 10, the patient can be sent for transplant right away. That is the right time for transplant. However, if there is any sepsis, we can optimize, we can prevent organ failure, we can make him come down in the ARC score between day 4 to day 7. If he improves, maybe we can prevent transplant and medical therapy can be done. However, if it is increasing, ARC score becomes 12, 13, well, emergency transplant has to be taken in this patient. On the other hand, if a patient at the baseline has organ failure other than liver, extrahepatic, such a patient may be taken up for plasmapheresis or any artificial liver support. Stabilized, patient improves, he can go for an emergency transplant. If he doesn't improve, well, best supportive care has to be given. On the other hand, if the patient already has many organs, 3 or 4 organ failures, we can certainly say, well, supportive care is the best care. If there is sepsis at any time, we have to prevent, and therefore early recommendation is to make the ARC score at day 0 itself. So just to give you, this was published in the APASL journal, which has a good impact factor. I encourage you as one of the members of the journal to please support the journal and give your best contributions to the APASL. I would like to take a minute, if the chair permits, about the APASL's initiative on APASL COVID liver injury spectrum study, acronymed as APCOLIS-1, which is still going on. We have submitted data of 408 patients, and I thank George and other colleagues from China, Korea, and our president from Thailand. Now India, our own center, has close to 46 patients, but this was the APCOLIS study. 408 patients, cirrhosis 43, and CLD without cirrhosis 185. Just to give you an idea that the CLD without cirrhosis versus with cirrhosis, you can see that the severe disease increases. So those who have got severe disease have more COVID. Also, liver injury is more, mortality is more, and therefore survival will be poor if you have an advanced liver disease. Liver disease was not in the comorbidity. Diabetes or blood pressure, hypertension were there in comorbidities. Liver disease is not. So the APASL's initiative is, while a COVID patient comes, include this into the comorbidities. I also want to introduce a new study from the APASL. This is, APASL has published the guidelines. George, Lau, and Manoj published on behalf of the task force the guidance for COVID in liver disease patients. Now this study is based on the attitudes and practices, what we are following as hepatologists across the globe. This is the monkey survey. We want to launch it today as APCOLIS COVID Task Force Initiative. For what are our attitudes? Please spare 10 minutes and go to this monkey link. With that, I will conclude today's presentation on ACLF and update. Thank you for your attention.
Thank you very much for extensive and very practical overviews of the ACLF. Now it's time for questions. I think there going to be many questions from the audience. Let's start. There's a question whether can the beta blocker be given even the patient doesn't have varices?
Yes, beta blockers can be given. In fact, nearly 40% of the patients have high pressure, but no varices. And believe me, in 3 weeks to 4 weeks, they get grade 3 varices. Such rapid progression, and they bleed. So anybody who falls into significant portal hypertension that is above 10 millimeters, you can give propranolol or carvedilol.
Thank you. Professor American, please help me to ask the question as well.
Yes, I would like to ask one question, Prof. Sarin. If you look at the journal that came out in the Gut 2017, they were mentioning that they couldn't identify factors that cause acute insult in some 40 to 50% of cases. So in your experience, have you had that kind of experience? I mean, that you cannot identify the acute insult?
Yes, I agree. In a fair number of patients, we are unable to find the cause of insult, but this is about 10 to 15% of the patients, and these patients could have an underlying infection which develops after the virus. Most common cause after alcohol virus is indiscriminate use of antibiotics and NSAIDs and drugs and complementary medicine.
I was just wondering, if we have a patient with acute or chronic liver failure, and if you cannot identify the triggering factor, perhaps it would be prudent to assume that it could be underlying sepsis that has triggered it. That be your...
Yes, it could be sepsis, or it could be some other metabolic derangements because of the gut bacteria. We are working on it. It's an altered microbiome in ACLF, which leads to the liver failure, and then probably sepsis is one of the things which can precipitate. I do not deny it.
I would like to also, I would like to also invite the APASL Executive Committee and panelists to participate in Q&A as well. While we're waiting for more questions, there's going to be the question about the experience on stem cell transplantation. Do you have any idea for or experience on stem cell transplantation in SRF?
That's a very good question. Mesenchymal stem cells have been tried and very extensively in Taiwan and Korea. And not Taiwan, sorry, in Korea. And they have shown there is a immune modulation. There is a benefit in these patients. So there is a need of more work, but initial trials of MSC and acute and chronic liver failure are encouraging. We haven't tried, but we are almost ready to start.
And regarding to the beta blocker, many of SRF patients has hemodynamic instability. How do we substantiate the beta blocker used in SRF, and what is the appropriate dose of study?
It's a very, very good question. I don't have data. The study is in progress. In such patients, we generally combine midodrine with beta blockers, and we do not use carvedilol, we use propranolol. So what happens, you raise the blood pressure on one hand with midodrine, and then you achieve portal pressure reduction by giving propranolol. It works well.
Prof, can I ask you one very simple question? Between propranolol and carvedilol, what would be your preference?
For a patient with liver failure in ACLF, if I am now asked, I would still say propranolol is a bit safer, but there is no data. There is only anecdotal data. Carvedilol is extremely good till the time patient has refractory ascites, because then it causes very rapid HRS. We are only using carvedilol. So in our experience, carvedilol is better. But theoretically, if you have an advanced liver disease or AKI, I would not give carvedilol. I would say low dose of propranolol is okay.
Professor Sarin, since COVID-19 has such an impact in the patient with chronic liver disease, but haven't been considered as a predisposing for the COVID-19, how about it? Is it considered as the precipitating event for the SRF?
Well, out of our 43 cirrhotics patients, the acute decompensation plus ACLF was 1 in 5. 9% had presentation as ACLF and the remaining has acute decompensation. Now the question is, this is an extrahepatic virus. This is not a hepatotropic virus. How does COVID cause direct liver injury? So now we have unfortunately some deaths. We are doing liver biopsies and trying to see whether the virus is there and whether it is having antigen expression in the hepatocytes. As of now, the cause of death due to COVID or decompensation is probably a systemic cytokine storm rather than direct hepatic insult. It's acute liver injury because of hypoxia, because of ischemia, rather than primary liver injury.
Any comment or questions from the panelists?
Do we have lower limits of blood pressure to use the beta blocker, Professor Sarin?
Well, Professor Ghani, nice to see you. It's about, normally if you start beta blockers in a ACLF, it should not be less than 100 because it very rapidly acts. Because very high adrenergic tone, even small dose is enough. So I would not start less than 100 systolic BP.
Just final question for
This is Kadir.
Yeah, it's Shiv regarding the...
Yeah, may I ask one thing?
Yes.
Yeah, Professor Sarin, there are many definitions of the ACLF. And I wonder, is it possible to make a consensus between all the centers and societies for the definition of ACLF?
Well, I think it is the need of the hour. I will walk 2 steps forward. I would encourage that there should be a global study using both definitions, APASL definition, their definition. All our colleagues, there is a need for joining hands and a better, clear definition. I agree with you.
Yes, Professor Sarin, this is George. It's an excellent talk. It's really state of the art. And I'm sorry that the New England papers actually misquote our findings. Having said that, do you have a chance to measure the cytokine profiles in those patients with COVID and with ACLF, especially the IL-6 and the others related cytokine markers?
It's a very good question. We have complete bead array done in almost, I would say, 9 patients with liver disease, with all the cytokine data, but we haven't been able to analyze. I would be happy to share. It's a very good question. One of the patients, one of the observations is the TNF levels and IL-6 levels are not as high as in those with a normal liver. In a normal liver, IL-6 is 4,500, 5,000, but not with liver failure. So I think it's a compromised capacity. And second, before I forget, George, and you, thank you for noticing the NEJM. And if we are preparing a rebuttal, and I would like our task force of APASL and ARC to join hands and sending a letter to editor, if you can all, we will prepare and circulate, and if you agree to the concept, may please sign and we'll send it over.
Thank you. Thank you.
And Professor Chen, Professor Chen from Taiwan, congratulations to the excellent work done in Taiwan. And I think that really gives us a unique opportunity to hear from Taiwan because with the numerous publications, it's difficult to find official publications from Taiwan. And I hope that our Taiwan colleagues can share the experience more with the rest of the world, being one of the most successful communities to have the virus control.
Yeah, we are going to publish this very soon because we all hands in containing COVID-19. But you are absolutely right. And I also want to take 5 seconds to echo about cytokine release syndrome. You know, still a very important issue to be elucidated because we find COVID-19 can progress from mild to moderate to severe, particularly for ARDS syndrome with the cytokine release syndrome. So if you don't stop from progression, then you will find the patient go towards cytokine release syndrome, which cause death. So this is actually an early detection about the COVID-19 patient rather than only focus on infectious property. So I will echo all the experts from also from Sarin about how important it is identify the mechanism of the interleukin-6 in other markers.
May I answer with the permission of chair? I just saw the question and Professor Chung has asked a question, role of albumin. I'll just briefly say that albumin, role of albumin in ACLF is very doubtful. We published 2-3 papers on that in hepatology just to say that albumin is structurally modified in 15 minutes. There is an overloading in the normal albumin, 1 albumin molecule and 1 bilirubin. But in ACLF, 1 albumin is loaded by 3 bilirubin. So it's an overburdened albumin and therefore it's non-functional. Number 2, the form which is mercapt albumin, which is HNA2, if it is more than 12%, then patients die. Third, the ischemia modified albumin. All these are modifications of albumin which occur in ACLF. So the question remains whether you replenish the albumin or replace the albumin, and that is not solved. So just to give you a brief answer, role of albumin in ACLF is open to questions, and there is a trial, Asia trial. Maybe sometimes in a year we will be able to have more answers.
Thank you so much. I think for interest of time, we need to close the webinar, and thank you for both speakers, Professor Chen and Professor Sarin, for such a wonderful talk. We are so successful for this Saturday. So for those who are the viewer and the audiences in the webinar, please stay tuned every Saturday at 4 Beijing time. We're going to have the COVID-19 update as well as the update on general hepatology every week. See you then next Saturday. I would like to take this opportunity to thank all of our panelists and again, Professor Chen and Professor Sarin for such a informative, and I think this could be very wonderful for our young doctors. Thank you so much.
Thank you.
Thank you.
Thank you.
Everyone, yeah.